My name is Alan Tunkel, and I'm making this presentation on brain abscess on behalf of my co-authors Juan Giovannicloche, Jeffrey Rogg, and H. Richard Wynn. For most of this presentation, I'm going to talk about intraparenchymal brain abscess, but I will also end the presentation talking about cranial subdural empyema and cranial epidural abscess. Let's begin with talking about the epidemiology of brain abscess. The incidence of brain abscess in the United States is about 0.3 to 1.3 cases per 100,000 population. We're now seeing increased rates of brain abscess in immunocompromised patients, and this includes those who are infected with human immunodeficiency virus, are receiving chemotherapy for cancer, are receiving immunosuppressive therapy after organ transplantation, or have undergone prolonged corticosteroid therapy. This particularly increases the risk of brain abscess caused by fungal pathogens as well as Nocardia species. Overall in brain abscess, there tends to be a male predominance, and the median age is generally 30 to 40 years, but the likely age may vary based on the pathogenesis of brain abscess formation. For example, those who have paranasal sinusitis tend to be in the range of 10 to 30 years of age, and those who may have an otitic focus that leads to brain abscess may be less than 20 years of age or more than 40 years of age. It's important to look at the predisposing conditions for brain abscess. As you can see, a contiguous focus of infection is seen in about 25 to 50% of patients. These contiguous foci may be from things such as otitis media, mastoiditis, sinusitis, face or scalp infection, dental sepsis, osteomyelitis, or penetrating head injury. Brain abscess results from hematogenous spread in about 35% of patients. So these may be in those who have underlying lung abscess, empyema, congenital heart disease, bronchiectasis, infective endocarditis, who may be immunocompromised or have hereditary hemorrhagic cholangioectasia. But note that brain abscess is cryptogenic in about 10 to 35% of patients. So sometimes no matter how hard you look, you may not find an underlying condition that led to brain abscess in an individual patient. This slide shows the initial symptoms and signs in patients with brain abscess. Things that have been most common are headache, fever, focal neurologic deficits, and altered mental status. And you see the frequency range in a variety of studies. It should be noted that the classic triad of fever, headache, and focal neurologic deficits is actually seen in less than 50% of patients with brain abscess. So certainly the absence of these findings does not eliminate the possibility of the diagnosis. And again, you can see the frequency range of some of the other common complaints. In terms of clinical features, the location really does define how the patient clinically presents. And this is illustrated on this slide. So patients who may have an abscess in the parietal lobe can have headache or visual field deficits. Those in the frontal lobe may have headache, drowsiness, inattention, personality change, or mental status deterioration. In the temporal lobe, ipsilateral headache, aphasia, dysphagia, or visual field defects. And in the cerebellum, symptoms such as headache, nystagmus, ataxia, dysmetria, meningismus, and papilledema. So again, the location of the brain abscess will absolutely define the overall clinical presentation. Now, in terms of the principles of managing patients with brain abscess, lumbar puncture is generally contraindicated. That's because when you have a brain abscess, it's typically surrounded by cerebral edema. There may be midline shift, relative downward displacement of the brain against the brain stem, leading to the risk of brain herniation if the patient does undergo a lumbar puncture. The imaging diagnostic procedure of choice is magnetic resonance imaging, and the addition of diffusion-weighted imaging increases the diagnostic accuracy. So the sensitivity and specificity of using diffusion-weighted imaging is 96% for differentiation from cancers. The positive predictive value is 98%, and the negative predictive value is 92%. Computed tomography, CT, is reserved for patients who are unable to undergo magnetic resonance imaging. So let's show some examples. So this is an axial contrast-enhanced T1 weighted magnetic resonance image demonstrating two rim-enhancing masses of the left periventricular white matter that represent abscesses. The intraventricular enhancement is suggestive of ventriculitis. This is the axial fluid attenuated inversion recovery FLAIR image in the same patient demonstrating vasogenic edema surrounding each lesion. To understand additional modalities that may help, this is another patient, and the panel on the left is a transverse axial T1 weighted magnetic resonance image that shows a bilobe lesion in the right frontal lobe and a second lesion in the left frontal lobe. In the middle panel, post-contrast T1 weighted image demonstrates peripheral enhancement of two lesions and subtle enhancement of another lesion in the right frontal lobe. In the right panel, trace diffusion-weighted MR imaging shows marked hypersignal consistent with decreased water diffusion in the cores of all lesions, a finding consistent with multiple pyogenic brain abscesses. Getting back to the principles of brain abscess management, biopsy or aspiration done via stereotactic guidance is needed for microbiologic diagnosis. After this is performed, it's recommended to begin empiric antimicrobial therapy based on the patient's underlying condition and the pathogenesis of spread to the brain. So here are some recommendations for empiric antimicrobial therapy in bacterial brain abscess. So, for example, if the predisposing condition is otitis media or mastoiditis, likely organisms are streptococci, aerobic or anaerobic, Bacteroides or Prevotella species, or Enterobacteriaceae. The combination of metronidazole plus a third-generation cephalosporin, either cefotaxime or ceftriaxone, would be appropriate. If the underlying condition is sinusitis, in addition to similar organisms that you might see in patients with otitis media or mastoiditis, there's also the possibility of infection with Staphylococcus aureus. Empirically, vancomycin should be added to cover for the possibility of methicillin-resistant Staph aureus. In those with underlying dental infection, mixed Fusobacterium, Prevotella, Actinomyces, and Bacteroides may be there, in addition to streptococci, so metronidazole and a third-generation cephalosporin. And in those with penetrating injury or secondary to a neurosurgical procedure, besides Staph aureus, Enterobacteriaceae, Clostridium species, maybe even the possibility of Pseudomonas aeruginosa, vancomycin plus a third-generation cephalosporin should be given. In those with bacterial endocarditis, given the high likelihood of Staph aureus or streptococci, vancomycin would be recommended. And in those who have a bacterial brain abscess of unknown pathogenesis, a good empiric regimen is vancomycin plus metronidazole plus a third or fourth generation cephalosporin. An alternative in that situation could include vancomycin combined with meropenem. With regarding antimicrobial therapy in bacterial brain abscess, I want to make the initial point that the initial approach to the management of a patient with suspected brain abscess is a multidisciplinary one. So it should include a neuroradiologist, neurosurgeon, and an infectious diseases specialist. Once cultures are sent and in vitro susceptibility testing is available, therapy can be modified based on culture results. Antimicrobial agents should be selected that are able to penetrate the abscess cavity and have in vitro activity against the isolated pathogen. And depending upon the pathogenesis of brain abscess formation, combination therapy should be continued for the possibility of a mixed aerobic or anaerobic infection. So for example, if the underlying etiology was an otitis media or mastoiditis, perhaps only a gram-negative bacillus was isolated. However, that does not mean that anaerobes are not present. And besides giving a third or fourth generation cephalosporin, it would be important to continue metronidazole for the possibility of anaerobic infection, even if anaerobes were not isolated. And I will refer you to a table in our chapter which will give recommendations of specific antimicrobial therapy once organisms are isolated. The optimal duration of bacterial brain abscess is unclear, but traditionally it's been 6 to 8 weeks of high-dose intravenous antimicrobial therapy. Some experts may follow this up with 2 to 3 months of oral therapy if an appropriate agent is available, and still other experts may only treat with 1 to 2 weeks of intravenous therapy and then may switch to oral therapy if appropriate oral agents are available. But I would say most experts would give the 6 to 8 weeks of high-dose intravenous antimicrobial therapy. The optimal management of brain abscess usually does require a combined medical and surgical approach. The recommendation is to aspirate all brain abscesses that are larger than 2.5 centimeters in diameter, because they may be less likely to resolve with antimicrobial therapy alone. It must be noted that this recommendation is based on retrospective data, and there are no clear trials that all abscesses less than 2.5 centimeters need to be aspirated, but if they are not, careful follow-up is definitely needed. Procedures for surgical therapy have included burr hole aspiration and complete excision after craniotomy, although no prospective trial comparing these two procedures has ever been performed. In fact, complete excision by craniotomy is now infrequently performed because of the success of aspiration and closed drainage techniques. Although complete excision may be required for multiloculated abscesses in whom aspiration techniques have failed, for abscesses containing gas, or for abscesses that fail to resolve. Fungal brain abscess often requires a combined medical and surgical approach. This is because these fungal pathogens invade blood vessels locally, lead to a lot of necrosis of the underlying brain tissue, and may be less likely to resolve with antifungal therapy alone. It's also fine to initiate corticosteroids if there's evidence of cerebral edema or mass effect causing increased intracranial pressure. Some criteria have been developed for medical management of brain abscess. This would include medical conditions that would increase the risk of surgery, the presence of multiple abscesses in a deep or dominant location that perhaps cannot be aspirated, those with concomitant meningitis or ependymitis, or in those who have early abscess reduction with improvement on antimicrobial therapy. Abscess size less than 2.5 to 3 centimeters is also one of the criteria, but again, patients need to be followed very carefully to ensure that the abscesses are resolving appropriately. In terms of outcome, the mortality of brain abscess in the pre-antibiotic era was about 30 to 80%. You can see that before 1977, that mortality rate was also fairly high, about 30 to 60%, and then dropped significantly after 1977 to about 0 to 24%. And the reason for this precipitous drop had to do with the introduction of neuroimaging in the 1970s, which allowed a better diagnosis and follow-up of patients and the availability of more effective antimicrobial therapy. Factors that have been associated with poor outcome in brain abscess have included delayed or misdiagnosis, poor localization, abscesses that are multiple, deep, or multiloculated lesions, inappropriate antimicrobial therapy, highlighting the importance of having infectious diseases consultation involved, patients with large or metastatic abscesses, ventricular rupture, which can lead to mortality rates up to 85%, Fungal etiology, again, much more difficult to treat, especially in those who may continue to have underlying conditions that led to the development of the fungal brain abscess in the first place, extremes of age, or if patients present in coma. With that, I now want to talk about two other intracranial abscesses, cranial subdural empyema and cranial epidural abscess. Cranial subdural empyema refers to a collection of pus between the space of the dura and the arachnoid and accounts for about 15 to 20% of all intracranial infections. Cranial epidural abscess refers to a localized collection of pus between the dura mater and overlying skull. The risk factors for both of these infections are the same. Most commonly, sinusitis, which is the predisposing condition in about 40 to 80% of patients. But there can be an otogenic source, or it can occur after head trauma, after neurosurgery, and even hematogenic spread to the brain. The etiologic agents most often reflect what would be in the sinuses: staphylococci, streptococci, gram-negative bacilli, and anaerobes. But others have also been identified, and actually the microbial etiology is unknown in about 20% of patients with these conditions. The clinical features in patients with cranial subdural empyema is an acute course. So patients acutely present with fever, headache, depressed consciousness, hemiparesis, and seizures, as well as other features that are shown on this slide. This is because the collection of pus is very extensive in the subdural space and is leading to extensive pressure on the brain. In those with cranial epidural abscess, the presentation tends to be more indolent, with headache, fever, seizures, focal neurologic signs, and altered mental status. In patients with cranial subdural empyema, the diagnostic procedure of choice is MR imaging, which typically shows crescentic or elliptically shaped areas of hypodensity below the cranial vault or adjacent to the falx cerebri, an extensive mass effect on the ipsilateral cerebral hemisphere. MRI provides better clarity of detail than CT and can differentiate empyema from most sterile effusions and chronic hematomas, again with use of diffusion-weighted imaging. Empiric antimicrobial therapy, again, should be based on the pathogenesis, but it's most often sinusitis. In that case, empiric therapy with vancomycin, metronidazole, and a third or fourth generation cephalosporin, or vancomycin along with meropenem would be excellent empiric therapy while you're waiting for culture results from aspirated specimens or surgical specimens and in vitro susceptibility testing. Surgical therapy is imperative. Subdural empyema is a medical and surgical emergency. To show you some of the imaging, this is a patient who had frontal sinusitis with associated extensive subdural empyema. So in these images, axial flare MR images, seen here, and here show inferior frontal and diffuse right holohemispheric high signal proteinaceous fluid in the subdural space. In this image, diffusion-weighted imaging shows multifocal loculated sites of restricted diffusion empyema, consistent with the diagnosis of cranial subdural empyema. In terms of the surgical management, this is a large study of 699 patients with cranial subdural empyema and the mortality rate based on the surgical procedure. You can see that in patients who had burr hole drainage, their mortality rate was a little over 23%. Those who had craniectomy, it was 11.5%. And those who had craniotomy, it was 8.4%. So craniotomy seemed to be the most appropriate procedure and really allows the neurosurgeon to see the vast collection of pus and be able to evacuate it appropriately. However, I would say that the optimal surgical approach is still controversial. So when you're comparing craniotomy drainage with drainage after placement of burr holes, although this study suggested a lower mortality rate, selection bias may have played a role in these results because patients who underwent drainage via burr hole placement may have been more ill and at greater surgical risk. That said, craniotomy should still be done in patients in whom it can be done. So I thank you for your attention.